so I think we can start with our second session for part 2 of diagnostics. So again, good afternoon and welcome to the parallel session. Okay. So again, I am Dr. Hyacinth Valderrama from the Health Facility Development Bureau. I am a medical specialist and the session chair of this parallel session on diagnostics. So I have with me is Sir Ramon Tonato, a project officer from the Health Facility Development Bureau as well, will help me in coordinating this session. Okay, so again, the call for abstracts for this research forum resulted to 212 submissions, and these submissions underwent a stringent screening and selection process. So in this session, we shall acquaint ourselves again with 3 that have been successfully qualified for this presentation. So each of the research presenters in this session shall have 15 minutes to present their research papers. So afterwards, we shall have 10 minutes to answer the questions from the audience. And the audience is on mute during the entire session, but you can post your questions on the chat panel on this virtual session room. So you can see it at the bottom of the chat. The chat panel is at the bottom of the panel link below at the bottom of the screen. So we suggest to have a maximum of 1 questions per presenter only. And then identify your presenter first and then state your questions for the following presenter. So before we close the session, we shall have the synthesis and some onward announcements in the forum programs. Okay. Okay, so now we can proceed to our next presenters. So our next presenters for the part 2 of diagnostic, clinical, and public health track is Dr. Danilo Andro S. Garcia from Lucena United Doctors Hospital and Medical Center, and he will be presenting his study entitled Comparative Analysis between Automated SARS-CoV-2 Rapid Antigen Test and RT-PCR results with correlation to cycle threshold values using a field duplicate nasopharyngeal sample. And our next presenter is Dr. Anton Lorenzo I. Gutierrez from the Philippine Heart Center on his study entitled Accuracy of the Main Pulmonary Artery to Aortic Diameter Ratio in Predicting Right Ventricular Dysfunction among patients with acute pulmonary embolism. And I think our third presenter is currently unavailable to provide his presentation, but we shall recognize Dr. Lyle Cecil Velo from Tondo Medical Center on her study entitled Reliability of Mid-Upper Arm Circumference in Identifying Obesity Among Children's 3 to 5 years old consulting in the outpatient department of Tondo Medical Center. Okay, so without further ado, let's proceed with our first presenter. We have Dr. Danilo Andro S. Garcia from Lucena United Doctors Hospital on his study entitled Comparative Analysis between Automated SARS-CoV-2 Rapid Antigen Test and RT-PCR Results with Correlation to Cycle Threshold Values using a Field Duplicate Nasopharyngeal Sample. So Doc, the floor is yours. So good afternoon.
Thank you so much, ma'am. So good afternoon, everyone. It is really an honor to be part of this first National Hospital Week Research Forum. Thank you so much to all the organizers for this opportunity to present one of our works in line with our fight against COVID-19. Our research entitled Comparative Analysis between Automated SARS-CoV-2 Rapid Antigen Test and RT-PCR Result with Correlation to Cycle Threshold Values using a Field Duplicate Nasopharyngeal Sample. I am Danilo Andro S. Garcia Jr., the Chief of Ancillary Service of Lucena United Doctors Hospital and Medical Center, and my co-author for this research is Dr. Gerardo Carmelo B. Salazar. The World Health Organization reported that we are not yet close to ending this COVID-19 global pandemic caused by the SARS-CoV-2. Therefore, a rapid and an accurate diagnostic testing is needed for an effective isolation and early treatment of COVID-19 cases. As to date, the available diagnostic testing for COVID-19 are rapid antigen test, rapid antibody test, and RT-PCR. RT-PCR is considered as the confirmatory and the gold standard for COVID-19 testing. It has a lot of advantages and also some disadvantages. And because of that disadvantages, some experts and literature suggested to use automated quantitative rapid antigen test or the AQ-RAT. It was perceived that the AQ-RAT has benefits in terms of its shorter turnaround time, low cost, and a less complicated process. However, there are also issues in using AQ-RAT in terms of its low sensitivity, low specificity, and low accuracy. Some literatures recommended to use the CT value of the RT-PCR in some of the decisions in terms of COVID-19 diagnosis. The objectives of our study are the following. First, to compare rapid antigen test result with RT-PCR result using a field duplicate nasopharyngeal sample. Next, to find out correlation of rapid antigen test result with the CT value of the RT-PCR. And third, to determine if there is a significant difference on the rapid antigen test accuracy, specificity, and sensitivity between symptomatic and asymptomatic patients. This study was supported and financed by the management of LUDHMC and the board of LUDI. After securing approval from the ethics committee and consent from the respondents, a duplicate nasopharyngeal sample was collected. We have 4 groups of respondents. First are the AQ-RAT positive asymptomatic patients with a total of 212 respondents. Then we have an AQ-RAT negative and asymptomatic respondents with a total of 112 patients. Third cohort is an AQ-RAT positive and symptomatic patients with a total of 38 respondents. And the last are the 48 AQ-RAT negative and symptomatic patients. We record the result of the rapid antigen, the RT-PCR, and the CT value from RT-PCR. We performed computation and we compared AQ-RAT with RT-PCR, the AQ-RAT with the CT value, and we compared the result of testing between symptomatic and asymptomatic patients. After that, we do data analysis and we interpret the result, we drew conclusion, and we provide recommendation to some relevant interested parties in our hospital. For the result, Figure 1 is the comparative results of AQ-RAT and RT-PCR from asymptomatic patients. We have a total of 324 asymptomatic patients, 212 of which are antigen positive and 112 are antigen negative. Among the 212 antigen positive, 140 turned out to be positive for RT-PCR and 72 are negative. And out of the 112 negative antigen patients, 63 are RT-PCR positive and 49 are RT-PCR negative, giving us 69% true positive rate, 60% false positive rate, 31% false negative rate, and 40% true negative rate. From the asymptomatic patients, we have the accuracy of AQ-RAT equal to 58.3%, a specificity of 40.5%, sensitivity of 69%, and precision of 66%. Figure 2 is the result of the symptomatic patients. A total of 86 symptomatic patients, 38 of which are antigen positive and 48 are antigen negative. It has an accuracy of 86%, specificity of 87%, sensitivity of 84%, and precision of 84%, which was observed to be higher as compared to the asymptomatic patients. Figure 3 is the correlation of AQ-RAT result with the RT-PCR CT value. We have a total of 203 patients that are confirmed RT-PCR positive, 45 of which has CT value that is equal or less than 30, and 158 has CT value greater than 30. From the 45 patients with CT value equal to 30 or less than, the RAT positive are 43 and the RAT negative are 2, with a positive detection rate of 95.6%. And from those with CT value more than 30, it has a positive detection rate of 74.7%, with the overall positive detection rate of 79.3%. Figure 3 is for the symptomatic patients. 38 symptomatic patients that are RT-PCR positive and 29 of which have a CT value that is equal or less than 30, and 8 has the CT value more than 30. It has a positive detection rate of 96.6% and a positive detection rate of 25% among those patients with a CT value more than 30%, with an overall PDR equal to 78.9%. Based on the findings of the study, the following conclusions are obtained. First, the automated quantitative RAT has 86% accuracy, 87.5% specificity, 84% sensitivity, and 84% precision. From the result of correlational analysis, it indicates a poor performance of the rapid antigen for COVID-19 in detecting SARS-CoV-2 antigen in patients with low viral load, but a good performance in patients with a high viral load. Third conclusion, antigen test accurately detects SARS-CoV-2 in all samples with CT value that is equal or less than 25, which means that it can be used to detect severe and critical cases. Fourth, where samples had a CT value greater than 30 as quantitated by RT-PCR, the positive detection rate of the antigen test decreases. Fifth, rapid antigen turns out to be negative when RT-PCR positive samples have CT value that is equal or greater than 35, which means that it will not detect remnants RNA from the sample. Next conclusion, for symptomatic patients, assay performance of antigen is acceptable, though false positive and false negative results can still be generated for more than 10% of the samples. For asymptomatic patients, it has low accuracy, low specificity, and low precision as compared to the result of RT-PCR. From that conclusion, the following are recommended for policy implications. First, with short turnaround time, rapid antigen tests could therefore be used as a routine high-throughput test in a community and hospital setting, especially during this time of pandemic. Rapid antigen tests might be appropriate for rapidly identifying infectious patients with severe to critical symptoms compatible to a COVID-19 infection in a primary care setting. Third, we should perform an RT-PCR test in patients with symptoms compatible with COVID-19, even if the result of rapid antigen test is negative. Fourth, recommended to have a longitudinal studies with larger patient cohorts to substantiate our results and to develop new algorithms for COVID-19 testing. And fifth, combination assay of RT-PCR and rapid antigen tests will help estimate the infection phase of COVID-19 patients in routine clinical practice. Here are some of the references. And once again, thank you so much and happy afternoon to each and everyone.
Okay, thank you for that presentation, Dr. Garcia. Okay. So moving forward, we would like to call on our next presenter from the Philippine Heart Center with his study entitled Accuracy of the Main Pulmonary Artery to Aortic Diameter Ratio in Predicting Right Ventricular Dysfunction Among Patients with Acute Pulmonary Embolism. So we would like to call on Dr. Anton Lorenzo Gutierrez. from Philippine Heart Center. So good afternoon, Doc. The floor is yours.
Hello, good afternoon. Thank you.
Accuracy of the main pulmonary artery to aortic diameter ratio in predicting right ventricular dysfunction among patients with acute pulmonary embolism. I am Anton Lorenzo Gutierrez, currently a fourth-year radiology resident at the Philippine Heart Center, and this is my research. Pulmonary embolism refers to the embolic occlusion of the pulmonary arteries and is the third most common cause of cardiovascular mortality after myocardial infarction and cerebrovascular
Sir,
attack.
excuse me.
In patients with severe pulmonary embolism, right ventricular dysfunction secondary to pressure overload is
Yung
considered as the primary
PowerPoint,
cause.
may late yung audio. PowerPoint,
I
may
think, Doc,
lag
you can
yung
go ahead
audio.
na.
May lag po ba? Okay lang.
Ako,
Yung
okay
audio
lang naman po,
Sir,
Doc.
pwede
Okay.
pa repeat po.
Okay, I
sige
think
po.
can start from the
Ay, okay.
beginning.
Sige.
Wait lang po.
We apologize for the technical glitch. Okay.
Pulmonary embolism refers to the embolic occlusion of the pulmonary arteries and is the third most common cause of cardiovascular mortality after myocardial infarction and cerebrovascular attack. In patients with severe pulmonary embolism, right ventricular dysfunction secondary to pressure overload is considered as the primary cause. Available literature shows that pulmonary embolism patients with right ventricular dysfunction have twice the 30-day mortality rate than patients without. Hence, timely identification of right ventricular dysfunction is crucial in terms of pulmonary embolism risk stratification. Computed tomography of the pulmonary arteries, or CTPA, is the gold standard imaging for the diagnosis of pulmonary embolism, while 2D echocardiography is a widely used tool used in identifying the presence of right ventricular dysfunction. The general objective of this study is to determine the accuracy of the mean ratio of the main pulmonary artery diameter to aortic diameter ratio in predicting RV dysfunction among patients with acute pulmonary embolism, while the specific objectives are to determine the sensitivity, specificity, positive predictive value, and negative predictive value of the ratio of the main pulmonary artery to aortic diameter, right ventricle to left ventricle diameter ratio, and right ventricular enlargement. This is a cross-sectional study completed at the CT-MRI section of the Philippine Heart Center and done in accordance with accepted standards of the Institutional Ethics Review Board. All patients aged 19 and above who underwent CTPA from January 2014 to December 2018 and had undergone 2D echo within 14 days of the CTPA were included. Patients with concurrent disease that altered the size of the cardiac chambers and great arteries were excluded. A total of 39 patients were included in the study. The population was divided into two groups, those with and without right ventricular dysfunction. The diameters of the aorta, main pulmonary artery, and right ventricle and left ventricle chambers were measured in the hospital Picture Archiving and Communication System, or PACS. Diameters of the aorta and main pulmonary artery were measured at the level of the NPA bifurcation as shown in Figure 1, while the widest RV and LV chamber diameters were measured in a multiplanar four-chamber view as shown in Figure 2. Table 1 shows the demographic and clinical profile of the participants. Majority of the participants were female and the mean age of those with RV dysfunction is 52. Table 2 shows the diagnostic profile of the participants. All parameters show no significant difference except for the RV diameter to LV diameter ratio and RV diameter, both with p-values of less than 0.05. Analysis showed that mean pulmonary artery to aortic diameter ratio is 50% sensitive, 44% specific, and 46% accurate in predicting RV dysfunction, while RV enlargement is 83% sensitive, 59% specific, and 67% accurate in predicting the same parameter. Lastly, RV to LV diameter ratio is 75% sensitive, 67% specific, and 69% accurate in predicting RV dysfunction among patients with acute pulmonary embolism. Our findings can be explained by this pathophysiology. Once an embolus lodges into a pulmonary artery, focal hypoxemia develops and reflux pulmonary vasoconstriction is initiated, leading to eventual increase in pulmonary arterial pressure. The increase in arterial pressure translates into an increased RV afterload and RV strain, which if not corrected causes wall dilatation and eventually RV dysfunction. This finding complements the results of the study by Arauz and colleagues who found that increased RV to LV diameter ratio is correlated highly with increased patient morbidity, specifically ICU admission. Additionally, increase in RV enlargement likewise positively correlated with patient mortality as demonstrated by the study of Christensen and colleagues, who found that patients who died of acute pulmonary embolism had a significantly higher RV to LV ratio in comparison to those who survived. Also, our data analysis revealed that the difference between the mean MPA to aortic diameter ratio of acute pulmonary embolism patients with and without RV dysfunction is insignificant, and that an increased MPA to aortic diameter ratio of 1.1 is only 46% accurate in predicting RV dysfunction. In a study by Arauz and colleagues, they found that an increased MPA to aortic diameter ratio is not associated with patient morbidity or mortality. Hence, it can be surmised that it may not accurately reflect RV dysfunction and may not reflect increase in pulmonary arterial pressure. In conclusion, an increased MPA to aortic diameter ratio measured in CTPA inaccurately predicts the presence of RV dysfunction among patients with acute pulmonary embolism. However, an increased RV diameter and RV to LV diameter ratio can be used to predict the presence of RV dysfunction. The findings of this study adds to the growing literature that supports the utilization and consolidates the role of CTPA in the diagnosis of acute pulmonary embolism and associated RV dysfunction. It is clear that CTPA not only can diagnose acute pulmonary embolism, but at the same time can serve as a screening tool in identifying patients with RV dysfunction without the use of 2D echo. In line with this, we recommend that the presence of probable RV dysfunction be included in the radiologist's report if the RV diameter is more than 4.2 cm and or the RV to LV diameter ratio is more than 1.1 to assist clinicians in stratifying the severity of acute pulmonary embolism patients and help them manage accordingly. This study is inherently limited by its retrospective design. A multi-center prospective study with a larger number of patient population may reveal the real value of CT-derived parameters in predicting RV dysfunction. Lastly, a shorter time interval between the CTPA and 2D echo would be more reflective of CT parameters and RV dysfunction. Thank you.
Okay, thank you, Dr. Gutierrez, for your presentation on the accuracy of the mean pulmonary artery to aortic diameter ratio in predicting right ventricular dysfunction. So I think this is now the opportunity for the question and answer portion. So are there any questions from our audience on the chat box?
Yes, Doc, we have one question. I
Okay.
believe it's for Dr. Garcia. The question is from Mr. Jesus Emmanuel Sevilla. The question states, how was the CT cutoff value of 30 determined?
Yes, good afternoon once again. The CT value, which is less than or equal to 30, is considered to be the threshold for infectivity. And early publications with regards to CT value are implying that those with CT values more than 30 are not anymore infectious. But the CT value 30 will not tell if the patient is RT-PCR positive or RT-PCR negative, because there is different cut-off for RT-PCR positivity in relation that varies that depends on the reagent they are using.
Okay. Okay, Doc. Thank you for that. For answering your question. Okay. So also in line with the question from Mr. Sevilleja, I would also like to ask po, no, since the CT values as well as the infectivity is inversely proportional to the positivity of the antigen findings, no? How will you resolve the what do you call this? The 30 to 35 range, no? Especially if there are positive antigen findings with CT value that falls within that range, no? Will this be a presumptive diagnosis for COVID-19?
In our institution, clinicians use a combination assay combining RT-PCR and the rapid antigen test. And for example, for those patients who are already on isolation for more than 14 days, but it turns out that they still have a positive RT-PCR test, they check the result for rapid antigen test and the CT value. If their CT value is higher, like 36 or 35, and the antigen test is negative, then they decided to consider the patient as infectious, even though it is still positive for RT-PCR. So those are some of the recommended policies here in our institution.
Okay, Doc. So thank you for that. So is the rapid antigen test, was this compared also with the registered FDA test kits? Or is this also the test kits that you've used for this particular study? Was this registered FDA test kit?
Ma'am, the rapid antigen test kit was approved by the FDA. That's included in the list.
Okay, so this is not a pioneer study, no, or a validation study on your end, but just a parallel study to compare the CT values from NPS samples.
Yes.
Okay. So, okay. So, are there any questions from the audience? Okay. I think there are none. Okay. So, for the next question, for Dr.
I think we
Gutierrez,
have one.
I think, okay, sige.
Sige, go ahead, Doc.
Was ROC analysis done
Sorry, can we request Mr. Sevillena to indicate? Can we request Mr. Sevillena to indicate kung kanino presenter po ba yung question?
Sorry, for,
Sorry.
I'm not sure if
Rapid.
he's a doctor of, for rapid antigen and RT-PCR. I think he is pertaining to the curve, the ROC curve. Am I correct po ba? Oo, yung analysis of statistical analysis of the RT-PCR as well as the antigen testing. And this question po is addressed also to Dr. Garcia. Am I correct?
Yes, okay. Dr. Garcia.
Doc, would you like to answer that later on? Sige, I think we'll give him time. We'll give Dr. Garcia some ample time to answer the question since he has technical glitch in terms of his audio. Sige. He's just fixing his audio. Okay. So I think we can proceed to our next question. Are there any questions for Dr. Gutierrez of Philippine Heart Centers? I think there are none, no? Sige. Sige, I will just ask him for this particular question, no? So this is addressed to Dr. Gutierrez, and okay. So for my question, Doc, I understand that non-ECG gated CTPA derived right ventricular diameter and RVD-LVD ratio is more accurate in predicting the right ventricular dysfunction among patients with acute pulmonary embolism. However, based on your research findings, what are the other diagnostic utility of the mean CT, main pulmonary artery to aortic diameter ratio? Can this also be used as a surrogate marker for predicting pulmonary embolism? Or
That is beyond the scope of the objectives of the study. However, once we use CTPA, basically we can readily diagnose with a high percentage of sensitivity and specificity the presence of acute pulmonary embolism because it's the gold standard. Did I answer your question?
in terms of the main pulmonary artery to aortic diameter ratio, I think this was done via 2D echo. Am I correct?
We compared the diameters of MPA to aortic diameter ratio, which we measured in CT scan, and then we compared if there is right ventricular dysfunction based on 2D echo findings.
Okay, so you perform this, am I right, with CT scan, no? you measured it, you measured this via CT scan? In the CT scan
yes,
yung...
the
Okay.
diameters. Bali, gold standard is the 2D echo right ventricular fractional area
Okay,
change.
so you compare it with the gold standard. Okay,
Yes.
so I understand, no, you have classified as one of your recommendations that the main pulmonary artery to aortic diameter ratio has a certain criteria for helping clinicians also to diagnose acute pulmonary embolism, no? Are there are these supported by other journals?
Yes, as I have shown in the presentation earlier, several other researchers have shown that RV, actually it's not MPA to aortic, it's the RV to LV diameter ratio and RV enlargement that actually predicts the presence of RV dysfunction, not actually pulmonary embolism, because pulmonary embolism can be diagnosed in CTPA. What I wanted in this study is that to find a parameter that would predict RV dysfunction without using the gold standard 2D echo.
Okay. In terms of the MPA diameter and the aortic diameter ratio, I think you also mentioned this in your study, you know. It's diagnostic utility.
In this study, we found out that it cannot accurately predict MPA to aortic diameter ratio. It's not sensitive nor specific in predicting RV dysfunction. However, other parameters such as RV enlargement and RV to LV diameter ratio has a high sensitivity and specificity in predicting RV dysfunction.
Okay. Are there any questions from the audience?
I think the last one from Ms. Villejan na po yung last question from the audience. Is Dr. Garcia here po or available to answer this question?
Yes, sir. I'm here. With regards po sa question
Yes,
ni
hello po, sir.
Yes, with regards po sa question, we don't use ROC for our analysis. We just make use of the final CT value of the patients after all the cycles have been made.
Thank you, sir.
Okay po.
Thank you, Doc.
Did
that answer
yeah.
your question po, Mrs. Odette? Anyway, if there are any follow-up questions po, you can send them to the chat or by email and we'll do our best to forward it to our presenters. So I think we can wrap up the Q&A portion po, Doc Haya.
Okay, so
Unless may
I think there are none na. And there is a question also from Dr. Garcia. When is the rapid antigen test performed? Is there a specific time of illness, for example, for instance, wherein you perform the rapid antigen test parallel with the RT-PCR?
For those respondents included in our study, the rapid antigen test was collected at the second day after the exposure to a confirmed positive patient, or second day after secondly, after the onset of symptoms.
How about the RT-PCR? Was it also done at the same time?
The RT-PCR was done upon admission po sa hospital.
And they use the same sample, the
Yes.
NPS sample. Okay.
We collected a duplicate nasopharyngeal sample. So sabay po siya kinolect po.
Yes.
And then the first sample was used to test for antigen. And the second sample was used for RT-PCR testing.
Okay, thank you. Okay, I think there are no questions already. The questions for this particular session was
I think naputol po si Lucaya. Wait lang po.
so test for COVID-19 detection shows a good performance in patients with high viral load. The antigen test accurately detects SARS-CoV-2 in all samples with CT values of less than 25, which means that it can be used to detect severe and critical cases. However, can reach in predicting right ventricular dysfunction among patients with acute pulmonary embolism, predicting the right ventricular dysfunction among patients with acute pulmonary embolism, it is still recommended to use the non-ECG gated CTPA-derived right ventricular diameter and the right ventricular diameter to LV diameter ratio in predicting RV dysfunction among patients with acute pulmonary embolism. Given that the mean pulmonary artery diameter to aortic diameter ratio has a low accuracy, sensitivity, and specificity in predicting RVD dysfunction among acute pulmonary embolism patients. So I think this concludes our second session. So make sure that you are able to log on to this parallel session on time. And as some of you are aware, there are 30 papers out of 60 presented in this forum that are in the running for the best research paper. So congratulations to our research participants. And the winners will be announced and be awarded at the closing plenary session of our forum. So again, before the first National Hospital Week Research Forum closes formally, there is a link to the post-activity evaluation form that will be announced and posted in the chat box. And all those who will be able to fill up the online post-activity form will receive a certificate of attendance in return. Okay, so I'm giving the floor to Sir Ramon. Sir Ramon, go ahead.
Hello, thank you, Doc. Thank you po sa ating mga presenters, and of course, thank you din sa ating audience for listening and participating by asking questions. So again, thank you po, Lokaya, and just some reminders po sa ating audience. Please access yung ating closing plenary session via the link provided in the screen. I will also be sending the link sa chat po. So, ayan, na-send ko na. Just type that in your browser so that you can access na po yung closing plenary. The closing plenary po will be at 3:30 p.m. So, medyo maaga po tayo natapos for this session. So, feel free to visit the other sessions po since there will be part 2 of the other sessions as well. And you can check it doon sa ating email or sa HFDB po na website as I will flash here in the screen. Ito po. So, here are just some links and ways you can contact the Health Facility Development Bureau. Again, we thank you everyone for attending and we hope that you have a nice remaining day. Have a nice day for the remaining part of your day. So, ayun, see you po at the closing plenary. And thank you.